Now let's start rheumatoid group of disease. We are starting it with rheumatoid arthritis, and this is not to be mixed up with rheumatic arthritis that is seen in children after recurrent sore throats which are caused by group A beta hemolytic streptococcus. Moreover, rheumatic arthritis responds to aspirin. But the current topic that we are going to study is rheumatoid arthritis. And here we will be talking about usage of DMARDs, that is disease-modifying anti-rheumatoid drugs. Definition: RA is a chronic inflammatory disease characterized by symmetric, erosive polyarthritis. It is the most common form of chronic inflammatory arthritis. Since persistently active RA often results in articular cartilage and bone destruction, as well as functional disability, it is vital to diagnose and treat this disease early and aggressively before damage ensues. The incidence of RA increases between 25 and 55 years of age, after which it plateaus until the age of 75 and then decreases. Clinical features and patient presentation. Imagine a young female comes to your outpatient department and describes her complaint as follows: "I am usually late for work in the mornings because when I wake up, there is so much stiffness in my hands that even holding a toothbrush or doing routine tasks is difficult." She may also note that this early morning stiffness tends to ease with physical activity over time. Thus, a classic presentation involves early morning stiffness lasting for more than 1 hour. Pattern of joint involvement. The earliest involved joints are typically the small joints of the hands and feet. The initial pattern of joint involvement may present as monoarticular, involving a single joint; oligoarticular, involving 4 or fewer joints; polyarticular, involving 5 or more joints. Regardless of the initial pattern, the distribution usually becomes bilaterally symmetrical as the disease progresses. In established RA, the most frequently involved joints are the wrists, metacarpophalangeal (MCP) joints, and proximal interphalangeal (PIP) joints. Flexor tendon tenosynovitis is a frequent hallmark of RA, leading to a decreased range of motion, reduced grip strength, and trigger fingers. Hand and wrist deformities. Deformities can develop, though their incidence has decreased nowadays due to the aggressive use of targeted synthetic or biologic disease-modifying antirheumatic drugs, DMARDs, which we will discuss subsequently. Common deformities include Swan-neck deformity, hyperextension at the PIP joint combined with flexion at the distal interphalangeal (DIP) joint. Boutonnière deformity, the inverse of the swan neck, characterized by flexion at the PIP joint and hyperextension at the DIP joint. Z-line deformity, subluxation of the first MCP joint with hyperextension of the first interphalangeal (IP) joint of the thumb. This results from damage to the tendons, joint capsule, and other soft tissues. Piano key movement, a noticeable movement of the ulnar styloid. Inflammation around the ulnar styloid and tenosynovitis of the extensor carpi ulnaris can cause subluxation of the distal ulna, leading to this sign. Foot and spinal involvement. Feet. Although metatarsophalangeal (MTP) joint involvement is an early feature of the disease, chronic inflammation of the ankle and mid-tarsal regions usually occurs later and may lead to pes planovalgus, flat feet. Cervical spine. RA can also involve the cervical spine. For instance, while a patient with RA can practice yoga, they should strictly avoid headstands due to a significant risk of atlantoaxial dislocation. This can compress the cervical spine, leading to compressive myelopathy, which may eventually result in quadriplegia. Fortunately, the prevalence of atlantoaxial subluxation has been declining in recent years and now occurs in less than 10% of patients. Extraarticular manifestations. Extraarticular manifestations may develop during the clinical course of RA in up to 40% of patients, sometimes even before the onset of arthritis. Patients most likely to develop extraarticular disease typically have a history of cigarette smoking, an early onset of significant physical disability, and test positive for serum rheumatoid factor (IF) or anti-citrulline protein antibodies (ACPA). The most frequently observed extraarticular manifestations include subcutaneous nodules, Sjogren's disease, interstitial lung disease (ILD), pulmonary nodules, anemia. Up next, we'll be exploring the clinical management of rheumatoid arthritis. I'll walk you through the diagnostic criteria, essential lab features, imaging modalities, and treatment protocols. If you found today's breakdown helpful, please subscribe to the channel to catch the next lesson.